Good afternoon and welcome to Open Classroom. I'm Janet Gillow, the Director of Professional Development for the Brown School, Washington University in St. Louis. So glad to have you with us today. For our participants joining us on Zoom, we can't see or hear you. We also can't call on raised hands. But while this is a conversation that we want to have with you, so please do use the chat feature to send in your questions and comments as we go, so that this really is a group experience. Folks joining us on YouTube, we are so delighted you're here and we don't have a way to directly interact with you. But welcome anyway. I want to thank and acknowledge Atia Thurman, the Associate Director for the Clark Fox Policy Institute at Washington University. She's going to be with me helping to moderate the questions and answers with you in the chat. So please say hi to Atia. And then I want to just share with you a little bit what's coming up, some program notes before we get started. We're about to wind down and take a little bit of a break at the end of a very busy semester. Slightly looking forward to that, but not before we do two great things on Tuesday of next week. So Tuesday at 12:30, Stephanie Krause she's a Brown School alum. She has a brand new book out called Making It: What Today's Kids Need for Tomorrow's World. So she's going to be delivering a book talk, and we are fiercely proud of our alum on this publication. Hope you'll join her for that conversation. Then same day, Tuesday, 5 p.m., we'll be celebrating the Brown School's Graduate Policy Scholars, a group of amazing social work, public health, social policy, and art graduate students who've been doing policy research around advocacy, and they are there to present their final projects as they're culminating their master's degrees. So particularly if you're an alum of the school and you want to show support to this just really promising generation of next professionals, I encourage you to register. I will throw a link in the chat in just a minute. But today's program, it is Maternal Mental Health Awareness Month. To get us started on a really compelling program regarding equity, I want to introduce our moderator. Theresa Howard-Howell is an assistant professor at the Brown School. Dr. Howell's research focuses on examining and understanding social and cultural determinants of sexual and reproductive health among adolescents and women. She's particularly interested in understanding and addressing maternal health disparities experienced by Black women living in the US. So she's the perfect person to lead us in a conversation, We're Not Broken, Why Equity Matters in Maternal Mental Health. Please welcome Ty.
Hi, everyone. Thank you so much, Janet, for that introduction. And I will share my screen with you so we can jump right into today's dialogue, because I feel like we have a lot that we'll be covering, and I certainly want to leave time for you all to hear from our wonderful panelists. And so, as Janet discussed, today we are discussing how we are not broken, and more specifically, why equity matters in maternal mental health. So just to give a slight overview of perinatal mood and anxiety disorders. So a lot of people know that pregnancy and the postpartum period are really critical times for understanding women and other birthing people's risk for new and as well as exacerbated pre-existing mental health illnesses. The potential for mental health challenges may range from issues like the baby blues, which are more common, to issues like postpartum depression, mood disorders, post-traumatic stress, postpartum anxiety, as well as obsessive compulsive disorder, among other conditions. And so what's important to note is that postpartum mental health illnesses can be attributed to both physical as well as the psychological transitions that are associated with pregnancy and childbirth, and as well as having a traumatic childbirth experience, and as well as no or inconsistent social support, and of course, the racism in terms of how we frame and think of what it means to constitute an equitable birthing experience. So looking more specifically at the plight of Black women and Black birthing people. So according to some statistics, postpartum depression affects about 1 in 7 mothers and approximately 1 in 4 Black women. But women of color and low-income mothers are more likely to suffer from postpartum mental illness, but unfortunately, they're also less likely to receive treatment. And so some of the consequences of actually having a postpartum condition and not being able to receive treatment or to have some sort of support would include having poor mental health that leads to deteriorating physical health, babies that can also suffer from the struggle to form a secure attachment and bonding. And this also increases risk for developing behavioral issues and cognitive impairments at later points in time in life. And then this can also contribute to pregnancy-related deaths or mortality as well. And so when we think about what are these factors that really contribute to unequitable maternal mental health outcomes, so I have three different things that we can consider. First, we can, three different factors. First, we can look at the way that Black women engage with the current mental healthcare system, excuse me. So many women of color actually fear that child welfare services perhaps will have to follow up with them if they feel like that whomever it is that they confide in thinks that they're unfit parents. And so child welfare workers have been statistically shown to deem Black mothers as unfit at higher rates than they do white mothers, even when we control for factors like education and poverty. So having to engage with this level of the system may be a deterrent from people who need mental health support after in the postpartum period, but they are afraid of what that might mean for their children. And then also the screening tools that are used are not like a one size fit all capacity. So when you think about the language and the different scales, whether maybe the scale says depression, and sometimes folks in their more common language may say something like snapping out or being angry. Either way, there may be a disconnect with the language that's used and in terms of how you actually diagnose clinically whether or not someone is experiencing a mental health condition. Then as well as the experience of mental illness as physical symptoms, like instead of feeling like you are super sad if you're depressed, maybe you have a headache. Instead of having language to describe what anxiety feels like, maybe you have a tight chest. And so these are other things that may create situations where we miss the opportunity to actually understand the dynamics of what a client or a patient is describing if they do come to us seeking help and support during the postpartum period. And then last, we have the healthcare providers who essentially dismiss a lot of Black women's symptoms. And so sometimes they're normalized, i.e. you'll get over it, or they're ignored, your pain is not real. And so all of these sorts of concerns contribute to different factors of the reasons why we have the inequitable experiences that we currently do. And basically the panel today is going to provide us an opportunity to think about how do we actually advance equitable maternal mental health at this point in time. So I will stop the share of my screen so that we can engage with all of our panelists, because I do feel like we have been able to assemble a really dynamic group of people who are joining us today. And so at this point in time, I will be introducing or allowing our panelists to actually self-introduce themselves so that you can hear who it is that will be joining us today. And then we will jump into this conversation. And so basically in alphabetical order, I will call off the different panelists' names, and then they'll let us know what it is that they do, and then briefly share how they became interested in this work. And first, we will start with Valen Alford.
Thank you. I'm Valen Alford. I am a clinical social worker based in Durham, North Carolina. I own my own business called Vitality Wellness Solutions, which was created really as a space for me to promote pleasure and wellness. I'm also a sex therapist and sex educator. And so how I became interested in maternal mental health was when I worked after completing my graduate degree at Howard University in having several professional roles. I ended up being the pediatric clinic social worker at Walter Reed National Military Medical Center. And at that time, the PEDS clinic was making a strong push to screen mothers in the clinic as a medical home. And so I would get a lot of moms at the 2-week appointment, 2-week postpartum. And then just in general, I would get a lot of moms because a lot of times, sometimes children might be the scapegoat for different issues that adults are experiencing, but we see the outward expression in the kids. And so I would always start my visits with the caregiver, which oftentimes were moms. And so I would realize, mom is not well, and oftentimes that trickle down to baby or child. And so I really started to focus on the maternal mental health aspect as part of the mom baby team. And so all of the social workers who covered the OB clinic, antepartum, postpartum, the NICU, we were all cross-trained in fetal demise and pregnancy loss and just maternal mental health in general. And so that's where my passion began. And currently I work part-time as a psychotherapist with the UNC Women's Mood Disorders Clinic. So I'm really happy to be here.
And we are so happy to have you here today, Valen. Really appreciate it. So next up, we have Shanice Hinton. Thank you, Shanice, for joining us today.
Thank you for having me. My name is Shanice Hinton. I work at Affinia Healthcare, and I currently manage the Centering Healthcare Program, which is group prenatal care. And prior to that, I actually came to Affinia when we had a grant to recruit moms to participate in another program. And what I just initially started to think was people weren't participating in the program because they didn't want it. It was more so what I found out over time was people didn't know about the program and they didn't know about the services. And so people weren't just self-selecting not to participate in the program, but they just didn't know it was available. And so as I got to know our patients and started to see that there was a need for education around what services were available, I started to hear more about their stories and their experiences with pregnancy and became way more interested in what they were telling me. And some of those stories resonated with me. And it just really started to spark something in me that let me see that there was way more that the population of patients that we were seeing needed. And for the most part, they are African-American women. And an opportunity just came available for me to start to manage the centering program. And so through that, so many connections, I started working on a grant that allowed us to work and develop a new curriculum for African-American women specifically and address some of those needs that they had. So when you start to see like all of those connections, you're like, hey, this story is way too familiar across way too many people. And so I became more and more interested in working with women that are pregnant. And so part of that drive also led me to pursue a master's in social work at WashU. So that's my latest baby, but I am proud to be and happy to be a part of this discussion today.
And we are so happy to have you here in the Brown School as a student, Shanice, and of course, as a part of this panel today, sharing your expertise.
Thank you.
And no problem. And next up, we have Dr. Shannon Lenz.
Hi, I'm Shannon Lenz. I'm a clinical psychologist and associate professor of psychiatry at the Washington University School of Medicine, Department of Psychiatry. Through my work there, I am the director of research for our Perinatal Behavioral Health Service, and I also do some clinical work with our PBHS as well. I'm also really excited to be a part of the grant that Shanice was talking about in working with Affinia and other healthcare centers around the region and also in Kansas City. It's a really exciting project. I first became interested in this work, I remember in graduate school many years ago, hearing a lecture from an expert in postpartum depression. And she was talking about the biggest risk factor for postpartum depression was being depressed during pregnancy. And I was sitting there thinking like, well, then why aren't we screening and treating people during pregnancy? Why do they have to suffer until they're postpartum before we start treatment? And so that's been really my passion ever since. And I've been continuing to try to think of grants and bring the treatment to where women are, and that's in OB clinics. So I'm really excited to be part of this panel. Thank you.
Awesome. We're so excited to have you with us today, Dr. Lenz. And next we have Karen Mellington.
Hi, I'm Carrie. That's okay. Mellington,
sorry,
it's
Karen.
spelled wrong, really.
No, it's so correct. Oh, okay.
I
I'm
mean,
sorry.
it's spelled right, but many years ago they put a TH in there. So I don't know. It's Carrie Mellington. Thank you for having me today. I work for Generate Health here in St. Louis, and I am the manager of strategic initiatives for them, which is just a fancy title to say that I manage our perinatal behavioral health initiative, as well as our home visitation collaborative. I don't know that there's one particular thing that brought me to this work. I think it was just a building upon and learning in different instances that there's something here. And I was a teacher for many years, and I have 3 children of my own. And I then went to work as a family case manager for the WIC program in Illinois, and learned about Healthy Families of America. And it really just built from there of how are we treating families and screening moms and caregivers. And, that's just a really important piece that I think that's where we need to begin. And so here I am.
Well, thank you so much, Karen Mellington, for being with us today. I really appreciate your time. And finally, last but certainly not least, we have Sydney Love Wilson joining us today.
Hi, everyone. My name is Sydney Wilson. I am a social worker, I'm a doula, and a childbirth educator. I'm also the founder of From Sid with Love, and that is where I support pregnant and parenting families by offering doula support and childbirth education and parent preparation classes. I spent a lot of time working with families in youth development and nonprofit prior to becoming pregnant with my own daughter. And after giving birth to her, being a preeclampsia survivor, I really was inspired to go into doula work, wanting to support other women who look like myself that, needed that support and to fill in those gaps where really the medical system kind of misses out. And so, did my first doula training. And as I started supporting families, I quickly realized that I was using a lot of my social work skills and assets to really uplift the work that I was doing. And so through that, I've also birthed my own mentor program where I mentor social workers who are interested in becoming birth workers. But yeah, a lot of the work that I was doing and the trainings that I was taking, including the first doula training, really didn't touch on the mental aspect of pregnancy and childbirth and parenthood, because that's real. That's where I was inspired to go deeper and to focus more on supporting these folks in that space. So thank you for having me.
Awesome. Thank you all for being here with us today. So I will go ahead and transition into the questions that we will be discussing to basically give our audience and viewers a better understanding of how we can address maternal mental health equity. So the first question actually is related to health equity training. So basically, there have been studies that have identified that implicit bias and the lack of culturally appropriate care are contributors to maternal health disparities. So in response, the mitigation of implicit bias by strengthening the cultural humility of providers has been identified as a strategy to actually improve client/patient provider communication and service treatment. So in this regard, what are your thoughts on implicit bias training for maternal health providers? And do you foresee it as a plausible way to actually instill cultural sensitivity that results in equitable treatment? And anyone can answer if you want to, and I guess if you raise your hands, kind of facilitate that as well, since we don't have the same energy as being in person.
I will jump in and just start off by saying we, with our Elevate collaborative with our grant study, thought that it was so important that we made it part of the grant. So we are going to be requiring that our providers go through implicit bias, anti-racism, anti-oppression training as part of the program. And we will be measuring implicit bias, and we're going to be looking at provider outcomes and also our patient outcomes over time. And so we'll be able to look at some of those questions, but we thought it was very important.
Mm-hmm. Okay, thank you. Does anyone else, Valen, it looks like you're gonna add as well?
Yes, I will just say that I think that implicit bias and anti-racism training is very important in the maternal mental health space. But I think it's foundational. Like, I think that, especially last year with so many different things happening with the pandemic to George Floyd, and just a lot of different things coming to the forefront. I think that there was this big push with a lot of systems, a lot of different entities, and I do think a lot of healthcare entities began to take a closer look to some degree. I can speak for the institution that I'm affiliated with, and making a concerted effort to offer training to providers. And so I think that that's very important. But I think that even providers, we're people, we're all navigating the pandemic as individuals and practitioners as well. And so I think having some training is definitely important, but it's foundational in the sense that it should be ongoing, and it should be, annual, much like the Joint Commission trainings that folks have to do, and that there should be some accountability with that, because what I have found, and speaking personally, I think a lot of people dissociate. You learn about it and it's very abstract. But as a Black provider, a Black woman who is there, and I happen to get a lot of the Black patients because Black people want to see Black people. So I get a lot of, Black women and Black parenting, birthing people, and we're having these conversations. And so what I find in my role is that I am serving as a conduit and a facilitator with medical staff, even with medication management. I'll be in a therapy appointment and someone is talking to me about why they aren't taking medication or questions that they had about it. And I'm asking, did you mention it? Did you bring it up? And, no, I didn't think they would understand, and things like that. And so I think sometimes when we're talking about implicit bias and anti-racism, I think when we talk about it as just a notion and as something to be aware of, awareness doesn't always trickle down to change in those interpersonal interactions where we're actually seeing on that individual level, like, okay, this person had a concern because there was with the prior pregnancy, she took Zoloft and it didn't go well, and so now she has some reservations, which has resulted in her not taking this medication. And I'm even having conversations like, do you want to take the medication? But just having conversations like, here are a range of, here's a variance of what some people who have the same diagnosis or these same symptoms may do. Some people do yoga, some people do medication, and sometimes people are like, oh, I could do that. So even just down to that level, I think sometimes when providers are thinking, because I think there's a natural response, right? Like, I'm not racist, or of course, I thought about this, and if this person is of color, then I made these considerations. But when we talk about these trainings as sort of like a check mark, I don't think it always leads to the trickle down on that individual empowerment level.
Oh yeah, and it's not perhaps a one and done sort of situation where it's the heat of the moment, so we roll out some sort of trainings just so that we are making sure that folks are aware that we care. But what happens once the heat dies down? So,
Right.
Carrie, were you going to add something as well?
Not now, because that's like you just hit the nail on the head. I mean, I think I would bring up also in this space, we talk a lot about taking community and centering community in where you are, in saying what is needed, what kind of training needs to happen and ongoing. And I think that is one of the best ways to bring to providers what's truly happening. That's the only other thing I would add.
Awesome. I totally agree. Does anyone else have anything to add to this particular question before we transition to the next? Other thoughts? Okay, so starting with question 2, we are going to discuss a bit about health policy. So Medicaid plays an important role in financing healthcare for low-income pregnant women. However, states are only required to provide coverage for 60 days after delivery for eligible individuals, despite many of the maternal health needs, particularly maternal mental health needs, actually occurring throughout the first year postpartum. So how can we contribute to legislation that better supports women and birthing people during the postpartum period? Any ideas or takers on what that might look like?
I would say that I know that there are a few, I want to say a couple states that just recently passed an extension. I want to say Illinois is one of them, but don't quote me on that. Where they did expand that that coverage to 1 year, and I think that other states should like literally follow suit, like just follow what they did, look at what they did because it is important, and yeah, and keep that trend going.
I think so too. Anyone else have any feedback to add to it? And so, and if I could elaborate just a bit from what I think it is that Sydney is discussing, there's a distinct difference between sometimes when we hear about Medicaid expansion, but where you are expanding who is covered by Medicaid. But this is in terms of an extension. These are folks who are already covered, but we are basically extending the parameters under which their coverage applies. And so this is a person who already has Medicaid. And so now, as opposed to just having it for those 60 days after delivery, we have extended the duration of time that they're covered for additional care and support. So does anyone else know of any other legislation or perhaps ideas about legislation that would better help support people during postpartum period? Or perhaps considerations for the current extension, of Medicaid?
What comes to mind for me is the whole conversation around infant mortality. And I think about like what we can do to support moms after that time frame that they've delivered, because a lot of times what happens is people don't have the supports that they need to be successful after they have a baby. So you get home, you have your baby, yay, I love this little baby, and then before you know, you're like, I'm so sleepy, I haven't eaten, like I didn't drink any water, am I still going to breastfeed? Like you have all these things going on in your mind, but you might not have supports that says, here baby, drink some water, here's a meal, let me hold your baby. And as this conversation becomes more and more prevalent around how do we support moms like after they have their baby, how do we support Black babies' lives after they are born, I think about things like making services available where we can pay someone's rent for a couple of months, pay somebody's car note. Like we're afraid that people aren't coming to the doctor, but why would we not give them a gas card so they can get there? That's like one less thing that they have to worry about. And when you think about like providing services that are warm and welcoming, and you want people to be honest with you and tell you, what problems they're actually having. But when they do, they're penalized. Somebody's calling DFS on them because, their baby didn't have on 2 shoes, for really, frivolous things that don't say, I love you as a person and as a new mom, and I care about you, and I want to see your family succeed. So I think about those kind of things, and don't get me wrong, we patients do need, tangible things like car seats and, pack and plays and Pampers, like all of those things. But when you think about addressing somebody's mental health, like after having a baby, not like having to decide between, will I stay home these 6 weeks or will I try to be in the best mental space I can be for my family and my baby and myself? And I think when it all boils down to it, we probably can get a borrowed pack and play. But if somebody can pay our rent or our car note or our car insurance, like that is what would give me a peace of mind while I'm trying to wait out at least that 6 weeks. But of course, like we've already mentioned, 6 weeks is not enough time. It's just not enough time. There are way too many emotions and hormones going through. And not to mention, like you're getting to know a whole new little person that changes every day. So that's what I would add to the equation.
And I think to some degree, what you are speaking of kind of alludes to conversations that have been had about the coverage of people like doulas and community health workers by insurance, by public insurance programs, so that there are opportunities for folks to come in to homes and actually support mothers and birthing people during that postpartum period. So do we have any other feedback about policy or health policy related contributions that could better help during the postpartum period? And if not, we'll transition into a COVID question because now is the time of COVID. And so basically, we know that COVID-19 has resulted in all of this social distancing, and especially restrictions that have disrupted access to some of the essential and the wraparound perinatal and postpartum care services. In terms of what has been the response, so now we have like telehealth and different other forms of remote delivery services that have provided care, and especially for some of the communities that are in greatest need. What do you think will be the long-term and mental health implications of COVID-19 on maternal health? And who wants to go? But okay, anyone.
I think it's going to be, I think it's going to be far and wide. And I think that we won't know for a long time, because I think we keep talking like COVID is over, right? Like we're through COVID, COVID is over. You know, we're opening up things and folks are expected to return back to work and return to doctor's offices and do all of the things that we may not feel safe doing. I think that, I think we don't know. I think it's going to be hard to put our finger on that. I also think that this ties into your previous question about how will we know how this is affected and what can we do, right? I know that ugly word of data, that data word. I think that we, you know, in order to make an impact on policy and on what this looks like as far as what COVID-19 has done to our communities, we're going to need to collect shared data so that we know what it looks like regionally and worldwide, so that we can impact policy and do things like introduce home visitation and build trust for families through pregnancy, early pregnancy, up to age 3 or 5. Right? Because that'll have an effect. It's known to have an effect on mental health and better birth outcomes and school outcomes and all of the things that follow children through their entire life. And also moms and families that are caregiving to these children. And so, yeah, I think we need all of the things so that at some point we could know, right?
I certainly agree. Does anyone else have anything to add to what Carrie has shared?
To piggyback on the last couple of this question and the question you asked before, I think that there will be some longstanding implications from COVID, and not all bad. On the one hand, as a provider, I remember a few weeks before the pandemic, before things got shut down here, we were having calls about telephone visits being illegal to bill. And so with the pandemic, we have been able to bill for telehealth and for phone visits. And with a lot of people being at home with multiple kids, with virtual learning, dealing with being a caregiver, some people have lost relatives. You know, there have been a lot of nuances that we've been able to navigate with the addition or with being allowed to bill for a phone visit. Like you could talk to somebody, but you can't bill for it. And of course, healthcare is a business, so you can't bill for it. We shouldn't be talking to people on the phone. But I know for a fact that there are several conversations that I've had telephonically and virtually that had it not happen, people and families would not have been well. And so I think, you know, there's an area of opportunity to continue to push, because now that things are opening back up, conversations are being had with healthcare organizations, with insurance companies about sort of timeframes to sort of push people back in. And there are some nuances clinically. You think about folks who might be in situations where there's interpersonal violence, or they don't have access to a phone or a private space, or they might need to be talking about the people that they're living with to process it in that safe space. So they might not have it in the same way, but I think being able to have the option, because I know some of my moms, like they're cooking dinner, so we might talk more about things that you could talk about in the open space. And then when they get back to the room after they, gotten kids on TV time or dinner or what have you, then we can talk about, okay, I can do my mental status exam or what have you. And so
Right.
I think there is an opportunity for us to advocate, whether it's at your business, your institution, in your community, with your local lawmakers. I've been signing on to letters like, oh, throw my name on that one. There's a big push. And now we have a vice president who is invested. She was invested as a senator, and she's invested as the vice president of the US in maternal mental health. And so I think there's a lot of opportunity for us to keep these conversations going, if nothing else, and just advocate that people do need access to services, to providers, to different types of services, like Sydney mentioned in the group chat. If there could be a place where we could pay for parenting and caregiving classes where people could have that opportunity. So I think that there is it's just a great area of opportunity on the one end for some of the implications from the pandemic. And as was previously stated, I do think that there are some things we just won't know about for a while, probably.
Right. And I agree. And I think with transitioning back to policy just a little bit, I do see we have a comment from Tanae in the chat box that said, if we consider like changing the definition of the postpartum period, that would be really instrumental in moving forward with policy ramifications, because most entities define postpartum as 6 weeks, when research shows that women often consider 1 to 2 years after birth as their postpartum period. So it would probably really make a difference in terms of what coverage would look like to better support folks at a later point in time if it's not within those first 6 weeks. Because sometimes you're still like, so I don't want to say shell shocked, but probably you are like shell shocked that this literally just happened. And so it's not until after 6 weeks that you're settling in. So like, okay, I'm like in this for the long haul now. So what does this really mean? So I think that is certainly a good consideration for how we might be able to do some work on this end to carry forward for legislation. And keeping with policy, transitioning a little bit to practice. So when we think about being guided by a reproductive justice framework, there is a mobile app that is called Earth. It's like birth without the B. So it's called Earth, and they use what's a Yep-like platform to review different to allow women and birthing people and fathers, partners, doulas, anyone to basically review or offer reviews of OBGYNs, the birthing hospitals, some of the pediatricians. And basically what they do is they turn that front end qualitative experiences into quantitative data so that you have information about the work of hospitals and providers to push for institutional change. And so Earth's experiential sharing platform actually creates the nation's first repository of experience of care among Black and Brown folks. And it provides qualitative data to help the consumers. And so what are your thoughts on this model? And are there any other strategies that you feel like Black and Indigenous people of color can use to prioritize their health and their safety when they engage with the healthcare system?
I love that app. I'm on the app myself. Like I reviewed my doctor and my care, my hospital and those things. And I encourage all my clients to do so as well, because I primarily work with Black birthing women or Black birthing people. So I love the Earth app and all of that. I think continuing to do that. I think community is really important. Like we know that. So like talking about things, right? Like not even just with other people as far as your friends, but like family is really important. Talking about what has happened in healthcare with your family and in regards to their hospital stays and the providers they've had to support them. But I also think learning about like your hospital's policies and things of that such, right? So like knowing about what hospitals in your area are considered baby friendly. I can't think of the website on top of my head, but there's a website where you can go and literally find out like, okay, did they make the baby friendly ranking, and what does that mean? most of the time that means that they are breastfeeding friendly
Mhm.
institution, which is super important, right? For moms who want to breastfeed. We know that when Black women go into hospitals, they're 9 times more likely to be offered formula. So even that, you know, you just had a baby, you just went through all this labor, your body and your mind are still, and then you have people offering you things that you don't want, you know, and it feels like you have to take it because it's this person in the white coat and this is their space because it's a hospital. And so I think just learning about the policies and learning about what's going on in the hospital before you step foot into the hospital is really important for
Mhm.
yourself and your community, because then we can, you know, use the Earth app to talk about that. And, you know, how do we get this to change? Because if this is a hospital that's the only hospital servicing a whole bunch of people, then we need that hospital to be baby friendly.
Right. I totally agree. Any other ideas or thoughts?
Hire a doula.
Hi,
I
Ursula.
was going to say that as well.
Awesome. And so how many doulas do we have on here? At least 4 right now? Yep. So hey y'all, we got some doulas who are also here. Does anyone else have additional feedback about perhaps how do we in turn, you know, prepare and offer strategies to Black and Indigenous people of color as they are preparing to engage with the healthcare system that might not look at them favorably?
I would just like to add that I think it's responsible as individual to take on ownership of your healthcare in deciding where you're going to go, what services you want, knowing what the services are. But I also would just like to play devil's advocate and say that I think a lot of that responsibility also needs to go onto the healthcare system, because they're receiving dollars from the services that they're giving me. And I heard in the past, someone once told me, get what you're paying for. So like, I think it should be a shared responsibility. I don't think, like, I get upset when I hear people tell Black and brown people, you need to advocate better.
Mhm.
Why? Why do I need to advocate better for myself when you as a provider, you have at least 2 degrees, I'm certain, or you wouldn't be here. So why do I need to teach you how to listen to me better? I don't know. I don't want to take us down a negative path, but I just think that it's equally important for medical institutions to take on ownership to make sure that they are training their staff to understand the needs of the patient and not push their agenda to become more lucrative financially.
Oh, Shanice, you know you are a person after mine own heart, which is so closely related to this final question that I have, and it's related to liberation. Okay, so I'll start it by saying this. A pretty complicated historical figure penned a quote that expresses, there is nothing more unequal than the unequal treatment of unequal people. So to provide additional context, equality involves giving different people the exact same services so that they can have success. However, we have equity that involves giving people what they uniquely need to be successful. And then even further, we have liberation, which is the practice of dismantling the sources that contribute to inequity in the first place. So because we live in a society that honestly does not equally view or value Black and Indigenous people of color in the same way as white people, how do we intentionally center joy and liberation in Black maternal health to be able to positively support better mental health outcomes? Okay, and anyone that has any feedback can share. And then also, I am going to screen some of the feedback from the chat box as well. So you all can share any feedback that you have about how do we basically intentionally center what it means to have joy and liberation in Black maternal health so that we better support mental health outcomes.
One thing that I will say in terms of centering liberation is something I find myself saying in session a lot, is holding space for ambivalence. So it kind of sounds antithetical to what you've asked, but I find that sometimes it's so freeing to say, it's okay to have a bad day, or it's okay if you have been feeling depressed, or, you know, whatever PMAD, whatever perinatal mood and anxiety disorder might be your diagnosis, your experience is common. It's okay. It's something to work through. And I think sometimes just calling a thing and saying like, you know, it can be a really challenging time. And I feel like every session, every time I'm talking to someone, I'm also saying like, and we also continue to navigate this pandemic, because there have been other, you know, large health issues, global health issues, but this is my first pandemic on this level, you know, so, you know, I'm always saying all the time, and I find like just having that space, sometimes it's just like, you're right. You know, like I have talked to people. I remember I was talking to one client, and she was just saying her mom told her that her faith wasn't strong enough because she was dealing with postpartum depression. And I just think culturally, just being able to penetrate some of the stigma that's around mental health in general, but especially when it's related to pregnancy and in the maternal, the fourth trimester, because I think there's this notion you should be happy, like it's such a joyous time. And so I think that a lot of liberation lies in just saying like, you can, you know, you can be exhausted and very grateful that you have a healthy, happy baby. Like you can be sad and you could have cried all night and you could be dealing with these things. And I have found that it has been helpful, at least I think it has. I've gotten some anecdotal feedback that it's just having permission to be, to have that ambivalence has been helpful for a lot of folks.
Thank you. That's awesome. Anyone else have any feedback in this regard? And also, if you are an attendee and you would like to either ask a question to the panelists, or you have some feedback, feel free to share it so that we can bring it to a part of this discussion as well.
I'll just add this comment. I think that doulas and a lot of the work that's been put forth to train and teach people of color like how to have those tough conversations around like the realities of their experiences when they do engage in the medical field has been, while difficult to verbalize your experience, I think it has also been liberating, because it's like the beginning process of accountability for what Black and Brown people expect when they go into medical facilities. And it's also given us a separate avenue to choose a midwife or home birth, or to have a doula, and to have those people to speak up for us when we can't. And I think that takes our power back in saying, I have a choice in the care that I get. I don't have to use my insurance at, you know, the local large hospitals. I can choose what's best for me and my family. And even though, you know, you in a white coat don't agree with it, this is freeing for me and my family. And I really find that that is something that is so countercultural, but at the same time, I see the enjoyment and the excitement on people's faces, that and the freedom that they feel for making the choice that's best for them, despite what broader culture says is right and respectful and what you should do because you're about to be a mother or a father. So I think constantly re-engaging in what does it feel like to be liberated and free from the stigmas that are killing our people is something that is a long conversation. And as long as we continue to have that conversation and to educate each other about ways we've become free and liberated and feel liberated, we're on the right path.
I think so too. And I think, Shanice, some of what you have alluded to relates to a question that we have in a chat from Laura that says, basically speaking about some of the ways that the midwifery model of care helps to reduce some of these issues that are related to poor mental health outcomes. Does anyone else have any familiarity about this particular model of care and how it helps to be a sort of opportunity to avoid some of the ways that the current system perhaps operates at a deficit when it comes to Black women and Indigenous people of color?
So I'm not a midwife, but I do, from my understanding, the midwifery practice, in my opinion, is sort of similar to like social work because it really centers that pregnant person, right? And the birth itself. Like it's not centered around medicine or procedures or things. It's literally centered around the natural process of birth. And so with that, you start where the birthing person is, just like in social work. And you go from there, right? And you address that individual's needs. And so I think that's really the key is that like it starts with that person. And then you branch out from there and then you create like your birth team and then you go further and think about what you want your experience to be.
Oh yeah, absolutely. And so with considering, what it means to have a positive birth experience and how to be able to better support maternal health in general, we do have a question in the chat that wants us to consider, like, what are some of the areas of maternal health research do we feel like is not currently getting enough focus? So if we really want to shift the way that things currently are, where can we start as researchers to address what some of these concerns look like?
That's
Such a big question.
Yeah.
I will jump in as the researcher. All of the things still need more research. We have this great drop off between, we have difficulty with screening women. And I think, making our screening tools more relevant, like you mentioned on your slide, and so that we're catching people, supporting providers so that they feel comfortable screening. Our providers at Barnes Hospital do a great job with screening, but we have a whole perinatal behavioral health service that has mental health social workers and therapists right there in the clinic with them. So, and that's something that, we've really worked hard on developing over time, but most providers don't have that. And then once women are identified, we have this huge drop off of who makes it into treatment. And then once people get into treatment, we have, many women don't get effective treatment or good treatment. So we have all these points that I think are really important places we could touch. We have all kinds of anxiety, I think, is really under-researched as well. Perinatal anxiety, we forget about the A part of the PMAD. So I think there's limitless directions to go. Happy to hear others' opinions as well.
Yeah. I agree, especially where the with the screening tools. I do use them. I'm thinking about like the EPDS is one we use quite often to screens for anxiety and depression. But sometimes, and especially in the virtual world, I may sort of I will provide a copy, but I'll also be kind of going over it. And I know even just talking it out, like there's a question that asks, I think the wording is something like, I have felt sad for no reason, but I'm talking to a mom who had a pregnancy, a fetal demise or baby in the NICU. And so she's like, well, is that yes or no? Or do I rate it high or low? Like, I have no idea. So that's one area I think with more tools that have some cultural sensitivity built into them. And then also, I'm just wondering, I don't know of a lot of them. I know that there are some research studies happening now, but does having access to mental health providers who are Black and of color, does that make a difference in the outcomes? Because I know that a lot of people that I'm working with will request to speak to a Black provider or a provider of color. And so sometimes it's just not, it's not an option in terms of whatever particular treatment they might be looking for. So I think that's one area of opportunity, especially for when we're talking about the health disparities with Black maternal health, having access to a Black provider. Does that make people want to come in more, or do people follow through more? Does that help some kind of outcome way? So I think that those are some things that come to mind for me.
Thank you. I think those are really good ideas too. Carrie, are you also going to add?
Yeah, I also think that if we go back to the telehealth or telemed, just like on one of your screens, the fear of being turned into social services. So when we're talking about true feelings, how we're feeling, what this is, and like was mentioned before, this isn't an either or, it's a both and. You know, I can love my baby and feel very overwhelmed, and like I don't have the energy to get up and feed them. But to say that out loud can have dire consequences, especially for our Black and Indigenous people of color. And so we've received a lot of feedback from our community. And what we are overwhelmingly hearing, is that this telehealth and feeling safer on screen than going in or having someone come into their home is a very important piece to move forward with. So I think, you know, just some research around how do we reimburse for that? How do we see that as medicine and as practicing medicine, or counseling or therapy or whatever that may be? And I couldn't agree more about needing people that look like the people they're treating, or some sort of similar experience and life experience. That goes a long way with our outcomes and our rates of show.
Right.
So
That's true, because representation, it certainly does matter. And to, I guess, kind of go back with some of the feedback that we've been discussing about research, is there anyone in particular that everyone can share about researchers that they know, perhaps? Because we do have a question in the chat that's asking the names of different researchers who are doing work in this area alongside of who's here. And I guess if you are actively doing research in this area, perhaps you can share a little bit about the work that you're doing specifically, so that they might be able to follow and see some of your work as well. And if not, maybe, you know, you could see about sharing them in the chat as you get them. I think the last thing that I would probably discuss is just giving an opportunity to share some different referrals or resources that you feel like would be very helpful for people to have, in terms of how they might be able to support postpartum moms, or something that they might be able to share if someone comes and, you know, wants some additional feedback, or where they can start to support a person who is experiencing some sort of needing some sort of postpartum support and help.
you are welcome to put my email in the chat, because I manage the Perinatal Behavioral Health Initiative with Generate Health, which is a network of providers who care for parents and families at all stages through, you know, prenatal and postnatal. And like I said, even some that go up to age 3 or age 5. And so we could, you know, direct you to partners that we have. We can direct you to the Perinatal Behavioral Health Initiative, our general body meeting, some different things like that. So there's quite a few resources in this region in particular.
Great. And if there are any books or apps or websites, anything like that, that you feel like would be also helpful for folks to have access to.
I often let people know about Postpartum Support International. They have a lot of resources for pregnant parenting folks, and then they do have a lot of some additional resources, or a separate area where they have some particular resources for Black moms and moms of color. And then there is an organization called the National Birth Equity Collaborative. They do a lot of reproductive justice work. I was fortunate to be on a call with them a couple of months ago with March of Dimes and the Department of Health and Human Services. So they're doing a lot of good work in this area. So they put out a lot of stats, information. And then I think there is Black Mamas Matter. That's another one. They have a lot of information and resources. So I know we're all in this digital age, so social media, usually if you put in PSI, Postpartum Support International, or National Birth Equity Collaborative, they'll start pulling up similar pages. And so you'll see the hashtags and things like that. And I think all of them are reputable and offer a wealth of information. So if you start with one, you'll see some others tagged, and some of those doctors and movers and shakers and doulas, nurses, social workers, all kinds of folks. And I'm also happy to be a reference as well.
Awesome. And we do have quite a few people who will also add into the chat box if you're interested in following along with those different folks who've been tagged and things like that. And so do we have any other questions before we take the time to redirect back to Janet? If not, I definitely appreciate all of you for taking time out of your Thursday to join us today for such an important conversation. I've had an awesome time speaking with you all, learned a lot, been able to laugh quite a bit too. And so I appreciate you all for being a part of this very important work and for wanting to see better for Black women and for other people who struggle with having an equitable birthing experience, an equitable postpartum experience. And certainly as a person who's also involved with the work and the research, I would like to encourage you all to stay encouraged, stay committed, and hopefully we can all be a part of this dynamic solution to advance health equity and reduce what the disparities currently look like. So thank you so much, and back to you, Janet.
Hi, thank you so much, panelists. This has been amazing. Really just such a pleasure to sit with you and with this wonderful audience, sharing resources back and forth. We are able to create community in this digital space, and it feels good. Atia, thank you so much for helping to support. To everyone, appreciate you spending the time with us. Appreciate all the good work that's being done out there to support moms, reduce these inequities, and have a healthier society together. So thanks for that. Everybody, please stay healthy and safe out there. We hope to see you again very soon at another open classroom. Bye-bye now.
Bye.